She's a true expert in the evolving landscape of geriatric care. She's a clinical associate professor at the University of Colorado School of Pharmacy. She's board certified in geriatrics, and she balances clinical care with impactful research, and she is part of the UC Health Seniors Clinic. So today she's giving us the highlight reel of the Beers criteria and their key alternatives to support prescribing. So please help me welcome Dr. Danielle Fixen.
All right, hello, good afternoon. I know this is probably not the best time to talk because you all may start to get a little bit tired after having a full belly, but I'll try to keep this engaging and exciting. I'm Danielle Fixen, and I'm excited to be here with you all today and talk about the alternatives to the Beers criteria. So here are our learning objectives. We'll evaluate evidence supporting the use of alternative medications and then apply the alternatives list to adjust medications in a patient case scenario. I'm going to barely hit on this slide. So the list we're going to be discussing today is an alternatives list for the 2023 Beers criteria. I think you all are aware of the Beers criteria, so I won't spend much time on that. But there is a group at AGS right now that is actually helping produce the next version of the Beers criteria. So one criteria that you may not be familiar with is a recent publication last July 2025, and it's an alternatives list to the Beers criteria. So if you think about the Beers criteria, it's a list of potentially inappropriate medications, also some medications to use with caution in our older adults. And one of the main pieces of feedback that is heard whenever AGS presents this list is, okay, you have a list of drugs we're not able to use. What can we use in these older adults? So they put together a list of alternative medications for patients. And there's a total of 21 conditions that they went through on this publication. And since I have 25 minutes, I'm not able to go through all 21 of those. So I highly recommend you look at that publication. It's free to look at. You can look at all of the great tables in there. I recommend pulling it up on your desktop because there are some really great links that you can also look for, like patient caregiver resources and provider resources. So for the talk today, we will be talking about pain, anticoag, insomnia, anxiety, and then agitation or aggression in people with dementia. So I tried to think of disease states where we commonly see patients who may be on some of these medications and want to know what the best alternative is, or maybe even what the best medication in that class is. Okay, so let's start out with our alternative treatment for pain. So all of my slides are going to be shown in a table that looks like this. We have our potentially inappropriate medications. So on the far left, these are the medications that are in the 2023 Beers criteria, medications that we want to try to avoid in our older adults. So you can see, TCAs are on there, NSAIDs, we have muscle relaxants, and then we have combinations of gabapentinoids with either opioids or benzodiazepines. So when thinking about alternative approaches to pain, the alternatives criteria list considering non-pharmacologic options first. So really trying to educate patients, consider different exercise therapies such as Tai Chi for some of our older patients, needling therapies, different stimulation techniques for our older adults, even physical therapy would be a great addition just to, help support patients who are in pain. And then the other thing that I really appreciated was breaking down some of the different medications that you can use depending on the pain type. So you can see we have our nociceptive pain and some of the medications that's recommended there, as well as neuropathic pain. Now you may be saying, wait, I thought it said you're not supposed to use gabapentin. So what the Beers criteria calls out is gabapentin in combination with other strong CNS depressants like opioids and benzodiazepines. So it's still okay, to use gabapentin for specific disease states, but again, just really trying to get the best picture of what pain looks like in that patient so we can use that medication safely and appropriately. I think one of my favorite things when I looked at the alternatives list is this resource column. So for each of the slides, I'm just including an example of one resource, but like for instance with pain, they have multiple resources. They have patient and caregiver resources as well as clinician resources that can be really useful, and you can just click on the link straight from that document to find some of those resources. So here on this next slide, this is just an example of resources that are offered. If you click on some of those links, you can see a pain management guide to neuropathic pain that has some really helpful information for clinicians to use, but then also if you're trying to talk to a patient about the type of pain they may be experiencing, and then some other treatment options that really compare different types of pain and the efficacy that these treatment options have compared to placebo. So one of the next alternatives is anticoagulation. I don't know about you, but I feel like 85% of patients I see in clinic are on an anticoagulant. And so it's really important that, when we're using these high-risk medications, we're making sure we use the medication that's most appropriate. So the Beers criteria in the 2023 version, they actually put warfarin and rivaroxaban as avoid use, and that was due to the risk of concern for major GI bleeding and just major bleeding in general. Now, dabigatran, it didn't make the potentially inappropriate medication list, but it's still on the use with caution list. So I think about, the Beers criteria as a stoplight and how the potentially inappropriate medications are more of that red light, hey, I would try to avoid using these medications if at all possible, versus the use with caution list is that yellow light. It's okay to use this, but make sure you have monitoring in place and make sure that you're assessing the patient to ensure that, dose is appropriate for use. In terms of alternatives to consider, so the alternatives list said, really we should be trying to have these patients on apixaban, and then they also listed edoxaban as well. And again, that's due, there have been so many studies. Actually, New England Journal of Medicine just, I think 2 weeks ago, had a study where they looked at apixaban compared to rivaroxaban and again showed decreased risk of bleeding and major GI bleeding. So trying to use apixaban if at all possible. However, there will be indications, where you may need to use warfarin, and that's okay. So that is acknowledged also. Another thing that I really think was important for them to put in there is they said pay attention to indication-specific dosing. I have seen so many errors clinically with the use of apixaban. So apixaban for atrial fibrillation, it has specific dosing criteria, specifically when we want to do a dose reduction. So with AFib, the general dose is 5 milligrams twice daily. However, if you have an older adult that's age 80 or older and also weighs less than 60 kilos, then they could be on that dose reduced dose of 2.5 twice daily. Also, if they have a serum creatinine greater than 1.5, plus either like the age or the low body weight, then that would be another reason that you would want to dose reduce. That is not the case for patients who are on it for a DVT, a PE. That dose is a standard dose. So I think, that was a really important call out, and I get a question at least once a week. It's more of a double check, like, hey, can you make sure I sent the right dose of apixaban? I want to make sure that I'm writing it for the correct indication. And then the other thing that they called out was that for patients who are using apixaban for, long-term prophylaxis or prevention, that after 6 months you can consider that dose reduction. So, if the patient's on apixaban 5 milligrams twice daily, consider that dose reduction to 2.5 milligrams twice daily. And again, there's some resources available here that you could use either to provide patients or caregivers with, and then a link to the guidelines as well. Okay, so let's talk about just a little case. And I wanted to spend a little bit more time on this next topic because it's a topic that I talk about almost every day when I'm in clinic with patients that I see. So chief complaint is I cannot sleep. I fall asleep okay, but wake up 2 to 3 times, and I'm not able to go back to sleep. It's a 78-year-old female that lives independently in a senior living facility. You can see the past medical history there. And then current medications. I mean, this is a pretty healthy 78-year-old, only on like 5 or 6 medications. So, but one of those medications being diphenhydramine, 50 milligrams nightly for sleep, that the patient's been taking for 3 months. The other factor is occasional glass of wine at bedtime. So what do we do with this patient who, their sleep is impacted, they're using a medication that's not appropriate? What does the alternatives list say? So potentially inappropriate medications are those benzodiazepines, Z drugs, antihistamines, TCAs, and alternatives to consider. So as you can imagine, assessing other health conditions. So assessing patients to see, do they have depression? Do they have anxiety? Are there certain conditions that are keeping them up at night or that are waking them up in the middle of the night? Maybe they have urge incontinence and they're waking up and getting out of bed to use the bathroom and unable to fall asleep. And then in terms of, first-line recommendations, so this hasn't changed. Our cognitive behavioral therapy is first-line recommended and has really great efficacy. Beyond cognitive behavioral therapy, so let's say, we talk to this patient, we're able to convince them, hey, you should visit with our clinical psychologist, and the patient says, okay, I've done this for a month now, but I'm still not sleeping well. What medications could we maybe consider in addition to cognitive behavioral therapy? So one that you may, remember from a long time ago is doxepin. So, you're like, wait a minute, it says TCAs on there. But this is specific to low-dose doxepin. So there's been multiple studies that have looked at low-dose doxepin, like 1 milligram, 3 milligram, 6 milligram, and they haven't found adverse drug events in older adults. So, you don't see that daytime sedation, the risk of falls and fractures. They've looked at that as well, and they've found that low-dose doxepin could be a safe alternative for older adult population. Another class of medications that I feel like has become pretty popular over the last few years are our dual orexin receptor antagonist, or you may hear it called DORAs. And so I've listed the 3 that we have on the market, daridorexant, limborexant, and then suvorexant. And then Ramelteon is also listed on here as well. Now I just want to give from clinical experience, patients that I've, we had a process where our pharmacy team collaborated with our clinical psychologist, and we were trying to get patients off of Z drugs and benzos for sleep. And Ramelteon would be one of the medications that we were recommending. Patients said it was terrible. So, maybe there are patients out there that respond really well. In my clinical experience, it's generic, but I have found that patients really don't like it, and they oftentimes will try it for about 2 weeks, and then they want a different alternative. So I do want to share just that clinical experience that I've had. Another thing that they note is that there's insufficient evidence for trazodone, mirtazapine, and melatonin. Now, does it mean that, if you have a patient, maybe they have depression and they're having issues with sleep? Sure, I think that could be an option where maybe you try trazodone, just if you want to try to better control depression. But first, if the primary issue is insomnia and they do want a medication, I would try one of these alternatives. Okay, so another common question I get, and this is, a little bit like an education for a lot of the providers I work with. They're like, I've heard that these orexin receptor antagonists work really well, but I'm still worried about like the falls and fractures with them. So there was a meta-analysis that looked at these medications. They specifically looked at falls and fractures of these medications and found that there was no increased risk of falls. So just something to give you a little bit of peace of mind when using these medications. We've had a few patients on these medications as well, and it seems to work pretty effectively for insomnia. In terms of medications, between the class, some clinical pearls just to consider is daridorexant is less likely to have daytime effects just because the half-life is a little bit shorter. It's about 8 hours versus limborexant has the longest half-life, so about 18 hours. So just something to keep in mind. Okay, and then this was kind of a trick that we found a few years ago. We've had a lot of patients who really sleep well whenever they're on a TCA. And so Silenor is one of the medications. It's the low-dose doxepin, specifically the 3 and 6 milligram tablet that's FDA approved, but it's really expensive, and patients have a hard time affording it. So there is an oral solution of doxepin, and it's 10 milligrams per mil. We've had some patients where we do a half mil, and we're able to get a lower dose, so like a 5 milligram dose. So another thing to consider. Okay, in terms of alternative treatment, next we're going to discuss anxiety. I think this is another, question I feel like that always comes up is, on the Beers criteria, antidepressants are listed. So what am I supposed to do with my patient, who has anxiety or who has depression? Well, first, I think it's good just to understand why these medications are on here. So, some of these medications can cause hyponatremia, ensuring that, if a patient is on an antidepressant, that we're talking to them about fall risk, especially as we're starting therapy or even titrating therapy. But then, even before that, I think just trying to understand and clarify the patient's symptoms. So if it's anxiety, what type of anxiety is it so that we can treat that appropriately? The other thing that they list here, which I think is really helpful, is talking about, they list it out based on the type of anxiety disorder. So you have generalized anxiety disorder, panic disorder, and then you can see other ones listed here. In terms of the resources, I think these are also really great resources to utilize for patients and for caregivers, especially if you have patients who are taking benzodiazepines for anxiety and we're trying to switch them to a therapy like an SSRI or an SNRI. How many people have used the website deprescribe.org? Okay, I see a few hands. If you haven't, I highly recommend checking out that website because it has really great resources for patients, and it also has some really good provider resources and good talking points for why patients should not be on medications like benzodiazepines for treatment of anxiety. This is just an example I wanted to share from the deprescribing.org website. So you can see here it talks about deprescribing medications, and then it gives recommended deprescribing. So it even talks through how you could go about tapering a patient off of a benzodiazepine. Okay, and then the last one that we're going to touch on today is alternative treatment, agitation in dementia. So from the Beers criteria, potentially inappropriate medications are the antipsychotics, and so avoid except for FDA-approved indications. You can see the alternatives to consider is trying to evaluate and address potential contributing factors factors. So try to figure out, why is there agitation in this patient? Trying different non-pharmacologic strategies for patients as well as another alternative to try. And this is where I think the resources that they have listed that's available are really good resources, especially for caregivers who are caring for a patient who may have agitation, offering them resources that they can try before we proceed with medications. One last bullet that they have is if non-pharm interventions fail, then antipsychotics may be used. And so the other thing they go on to say that when using antipsychotics, really try to start with a low dose and titrate slowly, and then do periodic assessment and evaluation of that antipsychotic. We know with antipsychotics, one thing that I think about is just the risk of falls because antipsychotics can be very sedating in our older adults. And we know that fall risk is highest in the first 30 days or the first 90 days of use. And so really trying to make sure that those patients are evaluated regularly and that when you are using antipsychotics that you're starting at the lowest dose possible. The other thing they put in here was about one of the new medications, brexpiprazole, and they just wanted to state in there what it's FDA approved for. So just ensuring that it's stated, hey, this is FDA approved for agitation in patients with Alzheimer's, and not shouldn't be used outside of this FDA indication. But they didn't give any, clear guidance on which antipsychotics to potentially use in patients with agitation and dementia. So this is just one of the examples of the non-pharmacologic strategies, so from the resources that I think could be really useful. Again, if you haven't looked at this document or this publication, it has really great resources that could be useful for not only clinicians, but also for patients and caregivers as well. And then because I have one more slide that I snuck in at the end just in case we had questions, but I really like this slide. We had a psychiatrist that helped us in geriatrics for a while, and she shared this resource with us just about the different antipsychotics. Now, I know brexpiprazole is not on here, but I think this is really helpful when you're looking at some of the side effects and knowing that, when you look at this list, aripiprazole seems to be pretty mild in terms of side effects. And I would associate brexpiprazole pretty similarly to aripiprazole in terms of side effect potential. But this can be really helpful when you're trying to assess, hey, which antipsychotic do I want to use based on side effect potential and maybe what you want to avoid in that older adult. So at this time, I'll go back. Did everyone get a picture of that slide? And answer any questions that you may have. It looks like we have about 2 minutes before I go red. Yes, question in the back. Doxepin used to for pruritus. Uh-huh. I think that is correct, yes.
Do you know what the dose is?
I do not know the doses, no. But I do know the lower dose, so the starting dose of general doxepin is 10 milligrams, and the sleeping, that is a newer dose. So I don't think it was anything less than 10 milligrams, if I had to guess. Yes.
Jumping back to insomnia for a second.
Yeah.
I feel like in clinical experience, there is a significant difference between kind of chronic primary insomnia versus the insomnia that patients experience sometimes for months or years after being weaned off of long-term dependence on a benzodiazepine, if they'd been on for many years before they came to us. Is there any physiologic difference? Should that affect our prescribing choices?
That's a great question, and I don't know that I have the answer for you. I would say I try to approach it, if this was a case that I had, I would try to approach it with evaluating the safest medication choice, but then also trying to partner with, our clinical psychologist to see if we can work together to help the patient. So I don't say that I would choose like doxepin versus a Dora. I don't know that there's enough information for me to choose one or the other. Yeah.
Thank you. Thank you. That was a wonderful presentation. The original study that came out on Rexulti, we did a journal club on it, and that study had some issues. You're nodding your head. Good. Is there anything more robust that's come out? Because to use it for agitation in Alzheimer's patients, I wasn't very convinced by that original article.
Yeah, nothing that I've seen from the original. I know that they're still doing, more, I think, long-term looking, but nothing more robust than that original. And I agree. I think there's been a little bit of a hesitancy, not only because it's an expensive medication, but really trying to figure out if there's clinical significance based on the data presented.
Yeah,
Okay.
I have one question.
Yeah.
So on the case that you presented, it mentioned snoring.
Yes.
So I always think about quality of sleep versus quantity of sleep. So before we start putting people on all of these, should we do nocturnal oximetry, sleep studies, which are not easy to do for long-term care? Thoughts on that?
Yeah, so I think the snoring is a good catch. Does the patient have sleep apnea potentially? And maybe if so, trying to, take next steps in that diagnosis and management to see if that improves sleep. So is that what you were getting at, like looking at sleep apnea? Yeah. Yep. All right. Thank you, guys.